Welcome to Dr. Jeffrey Roth's Looking Good and Feeling Great podcast, live from Las Vegas, with his co-host, Darrell Craig Harris.
Well, hi, folks. This is Dr. Jeffrey Roth, your board-certified plastic surgeon in Las Vegas, Nevada, and we're at it again.
Yes, it's. I actually have to see what number episode we're up to, but we've got quite a few going now, I think.
Yeah, I think I have to. I had to take off my shoes to count.
Exactly.
That. So yes,
and we've actually reached
our eighth season now, something like that. I can't remember.
And actually, we've reached I think almost 65,000 downloads, which is, for podcasting world, that's a good number.
Well, yeah, and that's everybody that's actually listening to us now. So thank you very much for doing that and telling your friends or enemies about us. So yeah,
absolutely, yeah. We definitely appreciate listeners, and it's exciting because we kind of started off with an idea to do this show, and it's kind of grown and grown. And
yeah, and we've been getting a lot of really good feedback, and this is what I want to hear about. And if I was in a room with a plastic surgeon, this is what I would ask them. Or people that have asked me these sorts of questions at charity events or boxing matches or whatever, we go ahead and we try to bring that here, because if they have that question, more people are going to have that question.
Exactly. And it's nice. It's nice for people to get information from highly qualified doctors. And we've talked about that, but you have a varied background, not only plastic surgery, but general surgery, emergency, being an emergency doctor in a very busy hospital. So you really cover a lot of territory.
So yeah, I've been blessed with the training that I've had and the experiences that I've had. I've been really, really blessed, and I get a lot of luck along the way as well. And I like to think hard work. But yeah, and again, I try to emulate the folks that trained me. What
right.
would Dr. Mathis do? What would Dr. Hoffman do? Okay, well, I'll do that.
Yeah.
So
that's great. And it's great to have those kind of mentors that are basically, those guys are internationally known.
Yes, and what's getting scary is you go to these meetings, and I'm not the young guy in the room anymore. All of a sudden, like, who's this young guy? Oh, what? So he's on the board. What? You know what I mean? So yeah, it's scary. And they're just actually, I was talking to Jack about this, and you're reading the paper, and a couple many.
We should say Jack is your brother.
Yes, Jack is my brother, and so thank you. And for you, those who just tuning in, and you read in little plastic surgery magazines that we get, and a lot of these guys that were icons are passing away now. Your Dr. Ian Jackson's, your Dr. Brody, a guy near and dear to my heart. So shout out to Dr. Jack Sheen, who was dear friends with my mother. He was arguably the best nose man in the world for decades, and such a nice man, and really reformulated how we thought about noses and rhinoplasty and how to fix them, and just a wonderful human being. And a couple things is I was finishing up. This is 20 years ago now. I was finishing up my residencies, my fellowships, and my training, and he calls me, and I was at USC County at the time, and he was up in Santa Barbara. And he says, I'm packing it in. He says, if you want to see me operate, you better get up here. And I'm like, oh, okay. So I was up there, and he had a bunch of cases, and it was just, it was kind of like watching Michael Jackson, Michael Jordan playing, Michael Jackson, performing, or Michael Jordan playing basketball.
Right.
I mean, you're just kind of like, oh, wow, look at that move, you know. And so, and the thinking behind it, and he explained it, and et cetera, and it was wonderful. And then another kind of aside, so we get done with the day and stuff, and so he calls me later on. He says, "Hey, what are you doing?" I said, "Oh, I'm just here reading and stuff like that." It was at some Hampton Inn or whatever up there. And he says, "Well, can you be ready in an hour?" And I'm like, "Yeah, sure." So we go ahead. So I said, "Where are we going?" He says, "We're going to art class." I'm like, "We're going to art class." Okay, we're going to art class. So we go ahead. We go to art class. It's some community center up in Santa Barbara. And so we're walking in, and it's a sculpture class. Okay,
interesting.
And so I walk in, a sculpture class, and there's about 12 people there with their sculptures they've been working on, their clay. And there was this nude model in the middle on this big thing like a Lazy Susan. Mm-hmm. And so the instructor would go ahead and kind of move the Lazy Susan around, like, oh, okay, well, I'll hang out with Dr. Sheen. So I'm there. And all of a sudden, the lady comes around and puts this big block of clay right in front of me. He says, okay, have at it. I'm like, oh, okay. So all of a sudden, I went from doing nothing, that day to, having a live art class with Dr. Sheen, and it was really kind of cool, really phenomenal. And then one more aside is that gal that used to take care of his patients because he had a recovery house, because people for him would come from Saudi Arabia, they would come everywhere.
Right.
And she would have what they call the nose house, because you'd have 4 people eating soup going, "Can you smell? I don't really know. Can you smell? Oh, I can't. Can you smell?" So, so she actually gave me his book. So, because he wrote all the big tomes of the book, and so I actually have Dr. Sheen's Dr. Sheen book.
Oh, okay.
In my blog, which is kind of a kick for me. So I know it's a little geeky. I'm geeking out right now, but yeah. And now that he recently passed away, that it really just, it was a real kick in the shins, because he was he hadn't operated, but he was a great guy, and they still present his videos and they still present his work, etc. So
it's so important to have mentors in whatever field you're in, right?
Sure.
People that you look up to and you can learn from.
100%. And there's some folks that you're like, okay, I'm not going to be him. You know what I mean? And that's okay too. But yeah, no, I've been very, very fortunate to have lots of folks that I could look up to and try to emulate.
So. That's one of the things we want to talk about today is implant malposition. And I guess that would be implant shifting and that kind of thing.
Yeah. So everything's great until it's not.
As is life.
As is life. Yeah. Well, and again, as a board certified plastic surgeon, what you try to do.
Actually, you're double board certified.
Well, there's that. I board certified in general surgery in case I ever want to do a hernia or some of a hankering to take some colon out. But which you never know. We go ahead and we see the patient, we talk to the patient, and we try to avoid trouble before there's trouble.
Sure.
Right? And so if somebody who's on a chemotherapy agent and steroids, and who's diabetic, and a big smoker, and et cetera, et cetera, et cetera. So some of those folks aren't the best candidates, and especially if they want to go 800 cc's and they weigh 95 pounds. Okay,
right.
Okay, well, time out.
So gigantic breast implant.
Right. So yeah, big as your head. So I'm like, okay, wait a minute. So you try to head off trouble before you find it, but sometimes it finds you anyways. And so again, you go ahead and we take your best efforts, and you think they're a good candidate, and you go to the operating room, and you put the implants in, et cetera, and everything looks great, et cetera. And and then the breast augs typically will go ahead and rise up a little bit because people go into spasm. And then usually about a month's time, they go ahead and start settling in, and usually can take, 6 months, 10 months, 12 months for things to finally settle in. And we have patients massage, and we have a little bandeau strap thing, and we have patients go to breast physical therapy. Yes, there's such a thing. No, you can't work there, Craig. So, but having said that, and they do a really, really good job. And they do cupping and stuff like that. They try to get people out of spasm. We put people actually on anti-spasm medicines, because we've found over the years, if you keep them out of spasm, you keep them out of pain. So anyway, So we do all the things you're supposed to do. Okay. And so in a certain percentage, sometimes the implant won't drop, or the implant, for whatever reason, will go ahead and shift over. Sometimes after trauma. By trauma, we mean traffic accidents, falls, that sort of thing. Sometimes people will do some inadvertent move in the gym, tear the capsule. The capsule is basically the surrounding of the implant.
Right, which we're going to talk about
later. We'll talk about it. Yeah, right. Okay, good. Yeah. So we'll talk about that in a second. So sometimes now you have a bigger capsule because it tore and then it kind of mended itself together. So now the implant is kind of sloshed around a little bit more. Most implants, most breast, if the gal lays down, will go ahead and go towards the armpits and down a little bit, because again, chests aren't flat, chests are round, and so that's kind of where that's driven to. So having said all that, sometimes the implant doesn't exactly stay where you want it, and that it can be an issue. And so then, again, like any problem, we say, okay, well, what's the diagnosis, what's the etiology, and then how to fix it. And again, my brain works least invasive to most invasive. So again, we try the least invasive stuff. We do massage, we do foam rollers, we do breast rehab places, we do Singulair, which is an asthma drug. Sometimes that'll soften things up. We do muscle relaxers. So we do all of those things. And sometimes that helps. Well, boom, and it falls into place and everybody's happy and, happy to live after. And then there's the surgical approach as well, where at the end you're like, okay, you've tried everything. It's, now this is just an anatomical problem with a surgical fix. And we go in there and we would take the implant out. We would go into the pocket, see what the issue might be there. We may have to stitch up the pocket. We may have to make a couple incisions in it. modify the pocket. Some folks, we also talk about different suture techniques. We talk about using the stuff called acellular dermal matrix, ADM or acellular dermal matrix. It's basically dermis off the shelf, and which is great. Especially we use it a lot in the burn world.
To replace skin.
Yes, to replace skin, and we use it in the reconstructive world, and then now we're using it in the post-complication world. And so we put that in, and that's really good as a buttress. It also is good for capsular scarring because capsule's not supposed to climb over it. And it's also good for real thin gals because it also gives you some soft tissue coverage in there. With that said, it's a bit expensive at about $2,000 a sheet for one breast, et cetera, et cetera. And then so there's that, and there's also this biomesh which we use, which is a little less expensive. And that basically will kind of hold on to things for about a couple years and then fade itself away. So there's a few things out there that we can use to go ahead and address that issue of implant malplacement or displacement.
Yeah, and I guess everybody's anatomy is different, of course. People have different levels of activity. So I guess that would all come into play in those issues. Right?
I mean, somebody who's a kayaker is going to be different than
yes.
somebody who is, just or just somebody who works at Pac Bell, as a CSA, customer service agent, all day. And so it of course it depends on the patient's protoplasm, and then how much they're really using stuff. So
and we talked about the capsule. So I know people have heard those terms in relation to breast implants. Can you explain what the capsule is? And I know you just did a recent procedure that you filmed. Sure. We talk about that too. That's on your website.
Sure. So anytime you put something in a body, right, whether it's a breast implant, whether it's a defibrillator, whether it is a chemotherapy port, whether it's a CAV implant, whether it's a testicular implant, a capsule will form around it. Okay. The body says, hey, that's not me. I'm going to wall that off a little bit. And so usually they're soft and everything's fine and all that. But sometimes, especially in the breast, 17 to 27% of the time, that capsule will go ahead and get a little firmer, a little harder, right? So that's what we call capsular scarring or capsular contracture, right? And we call it contracture often because scars contract, right? And that's especially a problem, say, in the burn world or the trauma world, especially over joints, because you don't want joints to contract up. You want to release them so they have full range of motion. Okay, so capsular contracture. So basically, as implants are in, they're settled in, and it may happen early, it may happen years later. Okay, so, and we don't particularly know why capsular contracture happens. It's kind of the bane of a plastic surgeon's life.
Right, because you can do everything right, and it
still happens. Happens at best of families, happens to me, it happens. I like to think that my capsular contracture rates are lower than most folks, but again, we still, if it's a 1%, I mean 17 to 27%, right? If it's
if you're the 1%,
if you're the 1%, then it's 100% to you, right? Yes. Or if it's 1% out of 200, well, that's two, a year, and it crushes me every time. So, but there are scales, it's gradation, and Baker, another luminary, passed away recently, classified it 4, 3, 2, 1, and 4 is like rock hard, boom,
right,
and 3 a little less so, 2 and 1. And so, again, you try to prevent it. Number one is you don't have blood in the pocket. You try to people to not have them smoke. You have the massage early. You do all the stuff we're supposed to do. There is some thinking of it might be some biofilm, and what that is, you put that implant in. You may have a couple little bacteria kind of floating around. You kill them off with the antibiotics, but they sometimes will secrete this little biofilm from themselves in the capsule. Right. And so they've seen that. So now in the capsule also, one is scars contract, number one. And two, in the capsule, there's this little thing called a myofibroblast, right? So a myro means muscle, a fibroblast type of cell. So sometimes we can go ahead and give these folks Singulair. Singulair is an asthma drug. It's Singulair. An asthma drug, which actually in some cases, the majority of cases, can go ahead and get the capsules to relax a little bit. Because the same receptors that you find in the bronchioles may cause asthma, you block them, same sort of mechanism of action, kind of interesting.
Yeah.
So sometimes we'll do that. And again, for me, least invasive, most invasive first. There's medicines for that, Singulair. There's massage. There's breast physical therapy. There's all those sorts of different things you can do. But then, okay, so now you have capsular contracture. The implant oftentimes will get harder and start rising up towards the clavicle, right? Sometimes it's painful if they roll over, et cetera, et cetera.
Sure.
Okay. Now, in the past, there's been folks that have done what's called a closed capsulotomy. And what that means is you go ahead and you just squeeze the heck out of it and you hope you crack it. Okay. That hurts, number one.
Yeah.
And number two, I mean, some of the old guys would have this thing. It looks like a big nutcracker. You know, it's like about the size of, cutting the lock off of your junior high school, locker. Okay.
Right,
and so you come walk in the room with this big thing and like the girl goes out the window. So we've kind of fallen away from that.
Yeah.
And some guys have done ultrasound. Again, it depends on who you read. So failing all that, then you're like, okay, well, now what? So now we go back to the operating room and what are our operative interventions? What are our options? So number one is take out the implant, take a look at the pocket in the capsule, right? So one is to do a capsulotomy. Otomy means make a hole in it, right? So otomy makes a hole. So in this particular case, especially if they're thin, because you want to preserve as much soft tissue as you can on there.
Right, because the skin, the tissue has to be a certain thickness,
well,
right?
Right, and especially
cause problems.
Right, and especially if they're real thin to begin with, and especially if they're on top of the muscle, so you're not working with a lot of space. So sometimes you want to recruit as much tissue as you can with that. And so you can go ahead and make a capsulotomy, which means make some holes in it. That usually kind of gives you enough room for things to again, start over, be soft, et cetera.
Right.
Versus a capsulectomy. Ectomy means take it out, right? So appendectomy, pancreatectomy, ectomy means take it out. So there's the ectomy part. And so in that regard, then you go ahead and you take the whole thing out. And then you wash the heck out of it and you get back to square one. You hope you get back to virgin tissue. Some folks will go ahead.
So if you take it out, do you is that the process? You take it out, you clean it out, put the implant back in?
Well, that's the great question. So my next sentence is, well, now you got to make a decision.
Right.
Because one, you put anything back in.
Sure.
One,
because you don't want to run right into the same problem.
So right. So and some folks are okay, I'm over it, but some folks, I really want it back. Do you go in the same pocket or do you switch pockets? So do you go from on top of the muscle to underneath the muscle, et cetera, to get into a quote unquote virgin plane where you may not have that issue? Because once you've had capsular scarring, yes, you're at higher risk to have it again for whatever reason it may cause.
When you're actually, so on that subject, when you're talking about on top or underneath the muscle, when you originally go in to do the breast aug, what's the decision-making process with that?
Yeah, it depends. Nowadays, and again, these are one of those things that we plastic surgeons argue about all the time and we never get our minds changed, for me, I like to go underneath the muscle for three reasons. One is I think it looks more natural because you have more soft tissue covering it.
Right.
Two, I think that they stay put longer. They don't slide down the chest wall as much. So again, less displacement. And then three, I think that they have less capsular scarring, less contracture, and putting them underneath the muscle. So for those three reasons, that's where I like to put them. Now, some folks can't stand motion because sometimes with underneath the muscle, the lady will fire her pectoralis major muscle and the implants will go up a little bit. Right?
Sure.
Now, some strippers use it as a marketing technique and go, hey, watch this, you know what I mean? But having said that, most folks, say, oh yeah. And
say exotic dancers.
Right. So, okay. But most folks are in the gym, they can kind of see it a little bit and, okay. But some folks are really bothered or it's very extreme. Okay. So those folks sometimes will go ahead and put on top of the muscle, or if there's some other compelling reason, if there's a chest wall issue or something along those lines. So again, it's judgment. As far as that goes, but by and large, we like to put them underneath the muscle unless there's a compelling reason to.
And when you have because with the capsular issue, if they're having like the hardness, I guess basically if they're touching their breast, whatever, it'll have a certain feel to it. Yeah, it just doesn't feel natural.
Right. So yeah, it can not feel natural, can be off a little bit, can be displaced, can be hard, all of that. Mm-hmm. And what we see a lot of that with is old implants.
Right. That's exactly I was going to ask you about.
So
that. Yeah.
old implants, especially those, and I live in a town where there were showgirls that have had these in since the 70s and 80s and all that stuff. And with those implants back in that day, the leak rate of the silicone implant was 50% at 10 years. Now that leak rate's down between 5 and 10%, depending on how you read. So, and the stuff that's in it, the actual silicone, used to be like maple syrup. And now this new one is cohesive gel implant, which is basically like a gummy bear. That's where you get the gummy bear.
Right. It won't spread if there is a leak as much as.
Exactly right. So having said all of that so some of these folks have had them in forever. And just recently we've had a string of folks come in and removal and replacement. And we had one gal that was in for about 32 years. Another one, I had another gal that was in for 32 years.
Wow.
One gal had significant leaks on both sides. This other gal had a little leak on the one side. But because of that, if they've been there that long with that sort of implant, et cetera, it was really like a rock, and it was really calcified the whole way around. And so we were able to go ahead and extract that. And if you go to our YouTube site and all of that, we'll be posting some film, and what you'll see me do is basically take it to the back table after everything is said and done, and I'll actually take a scissors and I'll actually open up, and you can kind of see the calcifications from something like this.
Because 32 years
it's a long time. Yeah. So you typically don't want the implants in there that long. If you can get a good 12, 13, 15 years out of an implant, it's pretty good. They're not permanent devices, so typically we take them out at some point.
Do you think most doctors, when they're putting those in, do you think most doctors, it seems to be responsible to explain, like, this is not something that's going to be in forever.
Yeah.
You are going to, I would assume most doctors actually explain that.
Yeah. So all the board certified plastic surgeons I know do that. And it's in every informed consent, and it's in every,
but still, some people don't pay attention.
Well, yeah, that happens as well. But for the most part, we try to educate best we can, and we do it verbally. We have cartoons on the website. We have everything. We try to do everything we can to get people.
I think
informed.
too, maybe because actually, what I've heard about that is from some of the TV shows that we've seen. That's a very common topic on those shows.
Oh, sure.
Where people will come in, like you said, they had implants in the 70s, 80s.
Sure.
Maybe now they've been in for 20, 30 years. It's like, should I get this changed? And the doctor's like, of course.
Yes. So yeah. Oh, no. Yeah. People will go ahead. When I was a general surgeon, people would come in these big, especially in Philly, they'd come in with these big lumps or masses and all that kind of stuff. And how long has it been going on for, sir? 25 years. I'm like,
wow, yeah.
Did you want to swing by? and so now, it's as big as your head, and it's on his back, and he can't put a shirt on, and it's, and it oozes, and you're like, okay.
And we had talked about this before somewhat, but maybe people that haven't heard the show, or they just started following us. The subject of saline versus silicone. How do you approach that when people come to you and ask you those questions, like what they should do? And
Sure. Well, again, you try to fit the patient for what they need, right? So basically, in our experience at the office, is we do about 80% silicone, about 20% salines nowadays. So the silicone gels now have gotten so darn good, and the numbers have gotten so much better.
Right.
So, and I think that they're safe. Otherwise, I wouldn't put them in. And again, you and I have talked about this a lot. Is the breast implant illness cases, et cetera, et cetera.
Right.
I think there is a number of folks in the population that it doesn't work for them, and then you take them out and they get better. So yeah, I think there is something to that. I think it's going to be more, talk the capsule again. I think it's going to be something in the capsule more than the implant itself. We are now
how your body reacts,
right? Or if there's a subclinical fungal infection, who knows? But at least we're studying that now. At least now, folks are actually sending these capsules and looking under microscopes and doing stains, and they're doing the PCR. They're doing all the stuff they're supposed to be doing to kind of figure out why scars contract, why capsules contract. And then also what is there that is maybe causing some of these illness problems. So to answer your question, is so 80% of the time we do a silicone implant, and then about 20% of the time we do the salines. And it really kind of just depends on the patient and how they want things to feel. Sometimes it's a price point issue. So really, it really sort of depends. And now some guys, and I'm busting on the LA, New York guys, because it's easy to do.
Low hanging fruit.
So it's just so easy. So and they're my friends, and it's just they're used to it. But some of the guys and gals will go ahead and say, oh well, I only do silicone implant. Okay, good for you, right? But we'll do obviously some salines as well. It really just kind of depends on the patient.
You mentioned there's actually a cost difference, which I didn't know. What is the difference in cost between saline and approximately?
It's I don't know for sure. I want to say it's 1,000 or 1,500 or something along.
So it's
something along those lines. So it depends. It depends on the patient and what their means are and what they want to do. If it's it just kind of really depends on that individual.
Yeah.
So
it's great to have options, like especially you said, as far as the placement options. That's great too, especially for people's different lifestyles. I think that's important. And as a doctor, how is important? How much is listening to the patient? How much importance does that place on your decisions about how you're going to treat them?
Sure. Well, they teach you in medical school that it depends on the number, but about 80% of the time you'll figure out what's wrong with the patient by the history, 85% of the time. So what they tell you, okay, is doc, it started here, and I had this pain, blah, blah, the redness. So if you listen to the patient, you usually can unless it's something weird, and then you need house, right? That you can go ahead and kind of figure out what's going on with that. So that's number one, before CT scans and radiology and before tests and before that kind of stuff. And if you lay a stethoscope on somebody and that sort of thing. So 85% of the time, you can usually figure that out if you listen to the patient. And as physicians, we have all of this external pressure to move faster. Okay. Right. So the government wants you to see somebody every 7 minutes. Okay. If you're working for, big hospital or big system or whatever, they want you to see everybody, 7. So it's hard sometimes.
It's a lot of pressure.
Right. Or they want you to come in, want you to come out. In the ER, sometimes you're the only guy down or gal down there, and you got 40 patients, you got to move. Right. So that, I don't know if it's doing us a disservice, et cetera. But having said that, is listening to patient, I think, is critical, which is why pediatrics is so darn hard.
Right, exactly.
Because you can't ask the 6 months old, hey,
why are you crying?
Why are you crying? Why are you throwing up? What's this red thing? How's it been on? How long has it been going on for, sir?
Right.
You know what I mean? There's 6. Okay, so months, and then you have to get the history from the parent, who may or may not be a great historian, or a grandma, or somebody who doesn't speak English, and that can be an issue. And then you have to get an interpreter and what's really going on.
And sometimes it's a situation where it's actually an emergency.
Of course,
you got to figure it out.
And you do the best you can. Yeah. So the answer is physicians interrupt their patients way too fast. Mm-hmm. They have to slow down and listen. If they do listen, usually 80-85% of the time, the patient will tell you what's kind of going on. And I like to listen to patients also and get a little bit into the motivation. Okay, well, why are you coming in for this operation? And again, I work for the patient. I don't work for the husband or boyfriend or
that's tricky, right?
Or that situation. Sort of thing.
Can be.
And that's kind of a classic, conundrum, et cetera. So there's that as well. But the main, I like to, and why are you getting this for? Oh, this is, and they'll go ahead usually, and when you get down to soup to nuts, you'll figure out why, and then you can best serve that. Okay, so whatever that true need is, then you can kind of go ahead and serve.
And do you think that's because I've sat in on a couple of your consultations. One was with my ex-wife, and we still get along, which is good. But what I liked about your consultation process was that you really take time and you really do listen. And with your goal going into a consultation, what is the ultimate goal? Is really to get to the root of what they really want and make sure they're going to be happy? Or?
So again, the goal in a trauma bay is to save somebody's life.
Sure.
Okay? The goal in a cancer operation is remove the patient from the disease.
Right.
So what is the stated goal? The stated goal depends on the patient. Sometimes, especially the mommy makeovers, it's I just want things put back where it used to be before the 7 kids. Yeah. I want to feel better myself. I just want to look better in a dress.
And you have to set realistic expectations.
Right. Somebody lost 100 pounds. Doc, I don't want to fold the skin into my pants anymore. Right. It says, I don't care about the scars. Put the scar wherever the hell you want. It says I got to fold and refold my skin.
Sure.
And they've done the hard work, and they've lost 100 pounds, and they've been on the treadmill, and they've done the diet, or they've done the surgery,
they have a lot of emotional investment.
Well, of course, and they've done all the work, and then me, I come in at the end with the white hat, and I put the cherry on top, and so for me, it's really a blessing to be part of that journey that they're on, and so. There's the classic moment, again, the classic Hollywood moment, we've talked about this, with otoplasty, where the 16, 17-year-old girl doesn't want to play sports, doesn't want to put her hair back, et cetera.
Explain what the otoplasty is.
So otoplasty is ear pinning, basically putting the ears back where they're supposed to be. These kids may have gotten teased mercilessly, et cetera, et cetera.
Yeah.
So with one operation, you go to the operating room, you put the ears back where they're supposed to be. And then there's the classic Hollywood moment where you give the patient the mirror and you unwrap, everything, and they look in the mirror and they start crying and mom starts crying, et cetera, et cetera. So the question sometimes also is, well, doc, what operation do you like to do best? And for me, it's the one that makes the most impact.
Right. Sure.
So whether it's the 16-year-old girl, we had another 17-year-old girl with size H, breasts or whatever. And we did.
That's really tough when you're a young girl in high school.
It's brutal.
Yeah.
And she was having problems in school about it, and she had neck pain and all that sort of stuff. And so, with one operation, she's a week out, and she always, my neck feels better. So some of our happiest patients are the breast
It's actually interesting
patients.
that you bring that up, because I have a friend that's a well-known singer in Las Vegas, and I had met her when she was 18. We did a show in Japan, and she had really large breasts, and she was a singer, but still. And then I ran into her many years later. I hadn't seen her, and another person that I knew, he goes, "Oh, she's a beautiful girl. She has really large breasts." And I said, "Well, actually, she had a reduction."
Right.
And that was kind of harkens back to that story, because with show business, obviously, in that people may want that look. Some people may want that, but some people don't want that look.
Sure.
And it's important for women that have that causes back problems. It causes all sorts of issues, right?
Sure. So and a lot when it comes to the breast reduction stuff, I think a lot of it is predicated, one, on mass, but two, on the pendulousness. Mm-hmm. And so it's just the drag and the pendulousness. And so it's kind of like if you have a backpack and the straps are too long, and then you shore up the straps and it fits where it's supposed to. Well, okay, well then it doesn't hurt anymore.
Yeah, it helps your whole physiology of your body, how you stand, how you present yourself.
Right. So all of that. So I think that's why I like to think I spend so much time. And we have these consultants come by and they go, "Oh, you're spending way too much time with your patients, doc." Right. And I'm like, "What?" And but for me, one is you can find out problems before the problems. By the way, I have this heart thing, and
I've always had issues when I had surgery or anesthesiology.
It's just we always ask about anesthesia.
Right.
But even so, we had to cancel cases just last week because somebody had a whole bunch of ibuprofen for a week before, and we're like,
causes a lot of bleeding issues.
And you tell them, but some people don't pick up on it, or they just go into automatic mode. We're all creatures of habit, and I have a headache, I have a toothache,
and also too, they want to get the surgery, so maybe they're not so forthcoming.
Well, there's that too.
I don't smoke.
And that's interesting. And we read them the riot act. And the ones smoking is bad and evil, and please stop it. Basically, especially for facelifts and tummy tucks and breast lifts, you cannot smoke. That includes nicotine from chewing or vaping or any of that.
And
part
of that is they're spending the money, they're making that investment, and then you want, as a surgeon, you want them to have the best result. Right. But they got to play their part. It's a team effort.
It's a team effort. And it's all about putting their ducks in a row, And again, we talked about this earlier, is you can't have surgery on Friday and expect to go back to work as a construction worker on Monday. Okay, that doesn't work. Depending on the procedure. But having said that, and then we go over that. We go over, hey, you're going to be out of work X, Y, and Z. Mm-hmm. You're not going to be able to twist your body so much. You can't lift more than 5 pounds. Oh, you have a 6-month-old at home. Okay, you're going to have somebody help you.
Sure.
Lift baby out of the crib. Says, oh, you have a 2-year. Well, you're going to have to herd him more than lift him. And so we talk about all that kind of stuff. I was like, what do you mean you don't have a car? Okay, well, you have to come back for your post-operative stuff. And so it's all of that.
And I think as a doctor, plastic surgeon, or no matter what you do, you want the best outcome ultimately if they're going to make that kind of investment.
Absolutely. And you do that as a physician anyways, even in the ER. It's like, because again, when I was back in Philadelphia, we had about 2 a.m, we would have, a lot of these moms that would bring their kids in at 2 a.m. to the ER because
things happen.
There's actual emergencies, but for sniffles, fever, chills. Why? Because they're at work all day. And they take a bus and 3 transfers to get to the ER. That's the only time they're going to be able to see a doctor is at 2 a.m. In the ER at MCP in Philly.
Sure.
And that's the most expensive care that you can get. But guess what? We talk about access. That's the only access that mom had.
Right.
And so you're like, okay. And then we talk about, where do they live? What kind of living conditions are they in? Are they going to school? Are they getting enough nutrition? So all of that
plays a role.
Yeah, falls under the heading of medicine.
What's your favorite part about being a doctor or plastic surgeon in general?
I think is being the ability to make the privilege to be able to make a difference in somebody's life and their families. So sometimes it's very dramatic. The gunshot wound to the chest, and you revive them, and you take it out. Okay,
Sure.
that's very Hollywood. And sometimes it's just a little thing that you do that'll go the long way, or make them feel about some of their lifestyle changes and just go, I need to do this. We had this one gal the other day. She was, we've been doing a lot of gauges lately of folks that come in and they have those big gauges in their ears. We've been repairing those a lot.
The big ear hole.
And this one gal came in, and she had a big gauge and it pulled all the way through. So she's got these two like dangling little pieces of tissue from her ear for 7 years.
Wow.
Okay. And so her kids were making fun of her and saying, "Hey, mommy, when are you going to get the lobster claw fixed?" Right. But she was afraid of doctors.
So nice.
Right.
Yeah.
She was afraid of. So finally it came into me. I guess I was less scary than most. And we went ahead and we did it. And I like to think that we made a big difference, in her life. A lot of these guys now were getting out of, thank God, the pandemic and stuff, are looking for jobs and such. Like, okay, well, enough already. I got to kind of clean up my act and kind of do this thing.
Right.
So, but
they got to go back into the professional world. Maybe they're salesmen. Maybe they're
100%.
Right.
So, or there's, okay, this was great while it lasts. Okay, enough already. And I'm on to make another change or whatever. So, and I judge no one. So I'm like, okay, well, let's fix whatever you need to get fixed.
Yeah.
So, and then, but I do like to go ahead and really kind of get to the reasons, kind of why, what's your motivation, what's your why of doing these sort of things. And it's usually to look better in a swimsuit or to feel better about myself.
Yeah.
I'm going to get, size G breast to get my husband back. No. Okay. So sometimes we'll talk a little bit about, that kind of thing as well.
Sure.
So it's
like
those
there is
sort
a
of
bit of a psychology involved in that.
Well, sure. Yeah.
Stuff.
Whether, a bartender or hairdresser or whatever, there's people are looking for connection, and that's where the social media, and they're looking for connection.
Yeah. And social media, now people are your face is right there front and center.
Sure.
So things that you
It's
maybe
a whole
might not have cared about 20 years ago.
Sure.
Now they do, right?
Yeah. So the whole Zoom meeting thing and more people.
We talked about, I even asked you about that.
Yes. So more Zoom meeting things. I don't like my this, my that. And so we're getting into that as well. But to your question is yes, for me, it's a matter of what can make the most appreciable difference, not for me, but for the patient. Because I can go ahead and say, wow, look at that. That's an absolute home run. Holy smokes, that's terrific. And the patient may go, meh. You know what I mean? So, okay. But then other times I'll go ahead and do a, relatively routine something, and it's the best thing since sliced bread.
And for some people, it could be life-changing.
And
they may have had years of, like you said, being made fun of or having being self-conscious about something.
Right. And then, and then again, getting back to other things is, 2 weeks ago, I had somebody tell me, says, you saved my life, right? I'm like, no, I don't do that anymore. So when I was in the burn unit, I was on a trauma unit. Yeah, okay, sure, all the time. But she said, no. She says, no, this had to get fixed, and I felt really bad, and I was really depressed and everything else. Or again, with breast implant illness, I'm gaining weight again, and my hair's coming back again.
It's overwhelming.
And the whole thing. And so even in my world, you're able to make an impactful presence, and not only for the patient, but then in whatever circle she's in, whether it's family, whether it's church, whether it's whatever it might be.
Whoever they happen to be interacting with.
Right. Yeah. And so for that's a real privilege. And it takes a while to train to be able to have the training and the wherewithal to get that privilege. But and I tell medical students, it's a calling, it's not a job. Yeah. But in my mind, it's well worth the sacrifice to do that.
Yeah, and that's great. I mean, I've seen you in action, and you can tell that you have a passion for it. You still love what you do, which is important, right?
Right. Still.
Yeah.
So I love putting my hard hat out and going to work in the morning and all of that. And I work with a great staff, except a couple of them. No, I'm kidding. I got a great. A great staff and
an awesome staff,
and that helps. That helps a lot too.
Right. Yeah, having the support because you can't do it by yourself.
No. It's a team effort, and it takes a village. And I say this all the time. I said, look, if the guy in the OR with the mop doesn't show up, that's a problem because you got to clean up, you got to sterilize, and guess what? I used to be the guy with the mop.
Yeah.
So
and it's good that
I get it.
And we talked about that before because we have similar backgrounds in some ways that we've both worked our way up from being that guy, being the janitor, being the whatever. And I did all that stuff too. But it makes you appreciate when you are successful and you actually arrive to that point, you really have appreciation for everybody in that office and everybody.
Sure. Yeah. So no. So if they don't do, if you have 11 Tom Brady's on the field, you're going to lose every time.
Right.
Okay, so you need one Tom Brady to be the
Everybody
quarterback,
plays a role.
but you need some 350-pound linemen. You need some wide receivers with 4.4 speed. Yeah, you need all those guys.
Right.
So
super important. Tell the audience how they can find you if they want to ask questions, and also the website. And
sure, we're all over the place. So check us out on the website. It is www.jjrothmd.com. That's jjrothmd.com. We are all over social media, including Twitter and Facebook and Instagram. And all of that, and we're constantly updating that. And if you want to see something on the website, or if you want to see something on our social media, let us know. We actually look at every single comment, etc. And then we also obviously are on the podcast as you're listening to today. And so if you're within the sound of my voice, you know that we are always available on Spotify, Apple, Podbean, and wherever else you have us on.
Actually, a special shout out to our friends at Mixerbox in Asia.
Absolutely.
We did a live with them a few months ago. They did really well. We're going to be doing some more of that coming up.
Yeah,
too.
that was a lot of fun.
Yeah.
And so it's funny because as you know, because you spent time in Japan and actually was over there for a couple of fights, you have to try to time things as well. And so getting up at 4 a.m. to go ahead and hit prime time there is always a challenge, but we're up for it. And that was a lot of fun. And we had some really good questions from there too.
Yeah, live from Taiwan. But thank you everybody for joining us. And please, you can find all of our episodes on all the podcast outlets. And please check out the past episodes. We have a lot of new fun topics coming up that we're going to discuss. And
absolutely, it's going to be a lot of fun.
Onward and upward.
Yep. And if you have a question that you want answered, by all means, let us know, and we'll go ahead and answer it on air. Or if you want to ask any questions about plastic surgery, aesthetic medicine, call the office. We love questions. That number, 702-450-0777. 777 is the biggest thing.
Yep. In the United States.
Yep.
Because we have overseas listeners too.
Absolutely. So yeah.
Awesome. Thank you everybody for joining us, and have an awesome day.
Thank you so much for joining us. For further information, please visit the podcast website link for Dr. Jeffrey Roth. See you next time.
Get the best skin protection from the ravages of the sun with Dr. Roth's really great sunscreen. Because you and all your loved ones deserve the best. Developed and produced exclusively by Dr. Roth. Really great sunscreen. For more information on looking good, feeling great, go to www.jjrothmd.com and check out the full range of non-surgical products.